on advancing equity in global cancer care for women. We are also grateful to partner with the United Nations Foundation and Global Health Council's Non-Communicable Diseases Roundtable. This evening's discussion will highlight the racial and geographic disparities in cancer prevention, screening, and treatment for women, especially those in low and middle income countries, Black women, and those in rural communities. We will also explore how implicit biases in healthcare and the financial burden of care prevents women from accessing screening and treatment, and how can WGH-DC members and partner organizations support programs, particularly that focuses on accessing screening and treatment. As we are here to celebrate the 5-year anniversary of the founding of our chapter, which was launched here at the UN Foundation on March 21st of 2018 by our founder, Nicole. WGH-DC is committed to carrying on the work of our founder, whose commitment to championing women in global healthcare leadership and fighting disparities in cancer care will remain part of our mission. As we reflect on the last 5 years, WGH-DC has been pivotal in influencing conversations in global health in Washington, DC, to be more gender transformative and intersectional. Some of the highlights include contributing our voice to universal health coverage and gender equality, climate, health, and gender, and engaging the White House Gender Policy Council to influence the development of the first ever national strategy on gender equality and equity. We take a partnership approach in our work and have worked with Global Health Council, Pathfinder International, the American Public Health Association, and the United Nations Foundation, to name a few. Our chapter will remain a place where individuals from different backgrounds, gender identities, and areas of global health can come together to spotlight issues we believe our collective voice can propel, particularly as it relates to a greater commitment on gender equality and women's leadership in health. Now I'm pleased to introduce Dr. Rupa Dutt, co-founder and executive director of Women in Global Health.
Thank you, Lanice, and really thank you all today for being here, and those that are tuning in virtually. Is by far my favorite room to be in, which is whenever I am with a Women in Global Health chapter. I feel like I am amongst dear colleagues and friends who are committed to advancing gender equality and women's leadership, but especially as we are at this moment of celebrating the 5 years of Women in Global Health DC chapter. It's a very special chapter for me since I'm based here in DC, and the founder of the chapter, a very dear friend of mine who passed away to cancer last year, Nicole Schiegg, as you've heard, created this chapter, and many of you are friends of Nicole. And I want to acknowledge all of the leaders of the Women in Global Health DC chapter, and thank you, Lanice, for your leadership, especially during these challenging times of the pandemic and many other challenges we're facing. You have steadfast kept this chapter going. I see many friends here in the room that I must also give a shout out to. So Liz, you've been with Women in Global Health before we had the DC chapter, and thanks for your leadership. Elizabeth O'Connell too, Lisa Hilmy, and many more friends. And we have Samega, who is the founder of the India chapter, and I'm forgetting everybody else, not because you're not important and valuable. It's just I would have a long list, and that just shows you how this chapter has brought a range of people together. I've been asked to focus today's conversation on the topic of really addressing women's cancer equity. There's going to be an esteemed panel that are experts that are going to go into deep issues, but there are a few points that I want to express on behalf of Women in Global Health. The first is recognizing that the women that are delivering the access to healthcare services themselves as health workers. We know that they face challenges in being able to do their job. At Women in Global Health, we advocate for women health workers. We know they're 70% of the health workforce, yet they only represent 25% of the leadership roles. And that affects cancer equity across the board, and especially for women's cancers. There was a very recent Lancet Commission looking particularly on the global health equity issues on women's cancers, and they talk about women's leadership as a key aspect, and particularly the women cancer health workforce. So I really encourage, when we talk about closing the gap on access to cancer care for women, we really also think about who is going to be critical in closing that gap. Another area that Women in Global Health has been doing work on is what we call gender responsive approaches to universal health coverage. And we know that the out-of-pocket expenses that women face are greater around the world. So that impacts their ability to be part of the preventative measures and to access vaccines. And then when there is a diagnosis, to be able to access the treatment for it. So it's the entire spectrum, and that's a critical aspect. And Women in Global Health did a report with Fine Diagnostics a few years ago where we spoke about our recommendations on getting testing into the hands of women. And some of the reasons we heard why women are not getting diagnosed is they're prioritizing everybody else's health and well-being in their communities. They're too busy. They can't afford it. They don't go until they're basically very ill because they are busy taking care of their households, their communities. We know that women have at least 3 to 4 hours of added care responsibilities, which we know has worsened in the pandemic. In many societies, they have restricted mobility and they're not prioritized within their household. There's also stigma associated with feeling ill. So we know there are a lot of cultural components into it. So when we're talking about closing the gap on women's cancer equity, we must also look at the root drivers of why women are not able to access the services. We'll also be hearing, I'm sure, about some of the interventions that can really address the solutions. But we are talking at Women in Global Health about looking at primary health care as part of a means for the preventative access. So while we do need specialized care, we want to make sure that when we're looking at closing the gap on cancer equity for women, that we're strengthening primary health care. We know that catching cancer early and preventative measures are going to be critical to the broader population agenda. And then finally, also talking about the overall loss when we lose women in our communities, and when we lose women as carers, as mothers, and as members of our families and to communities. It has implications to the wider family unit and to the wider community unit. So there is an exponential loss that we have when we lose women earlier than expected. So I know today's discussion is going to be covering a range of these issues, but really the message here is when we talk about closing the gap of women's cancers, we must ensure that women are at the decision-making table. We know that when women policymakers are in power, they shape what is invested in, and in the United States, we know that women parliamentarians have been responsible for getting increased funding into addressing the R&D, to having other policies on cancer. Second thing is to really think about the women who are delivering those health services and how to support them. And third is really to approach it from a life course aspect. And fourth is to really recognize the financial aspects of it. And so really, these are some of the key messages that I hope come out in today's conversation. And the final note I'd like to say, as I said, this is a room that I feel very comfortable in, is really bringing it home to the personal story. I lost my dear friend last year, and we just commemorated the 1-year anniversary of that loss this weekend. Esther, Nicole's mother, came up from Florida, and it was very raw for many of us to imagine that, after crossing 1 year, that those memories of that person and the person we lost was at a young age. Nicole formed the DC chapter, but anyone that knows Nicole knows that she has made an imprint on the lives of so many. And wherever I go around the world, and the organizations she's worked with, and since they know that I was part of her care team, they often say, well, we remember when Nicole, did this work, or, she was part of the WHO Economics Council very recently, and she's contributed to the five-year childhood campaign. And there's so many examples. And one of the things that I'd like to share about Nicole is till the very end, we were just discussing this past weekend, is that even the week before she passed, she was still working, and she was still working with the World Health Organization, thinking about ideas, and we lost her too early. And there's millions of women that we're losing around the world way too early. And so let's really make sure we prioritize addressing the cancer equity gap that is for women around the world. It presents itself here in the United States, and the initiative that Nicole, as part of her legacy, launched is called the Southern Roots Initiative. If you want to learn more about it, Elizabeth, myself are available to give you a bit more information about that. But we know that the equities are in our backyards as well as globally. So on that note, I am delighted to turn it over to Lisa Hilmy, who also does not need an introduction in this room, and I'm actually gonna give you the floor. Thank you.
Thanks. Yeah, thank you so much. I think I'll sit here for now. I think we're still waiting for Tamika, are we not? Or yes. So I'm so grateful to be here. It's such a special day on many reasons. I think being part of Women in Global Health, to see what Rupa's done with the movement across the world has just been something, amazing to watch it grow. And then, of course, for Nicole and the important conversation that we're here today to discuss with women and cancer. We have some great speakers that will tell their personal stories that will give us really incredible technical expertise that they've had throughout their lives and their careers. And will really encourage us on what will the next steps that all of us in the room can do. I think that I will welcome right now, if you can take, Anuradha is on Zoom, and so we'll show her in a second. And Erica, Dr. Erica Lieberman, I'm going to introduce you in a second. I'm sure each one of you there in this room has known someone, whether it be a family member, whether it be a coworker, or someone in the community that we have lost to cancer, or that has cancer and is a survivor. It is something that we cannot escape. And I hope that all of us leave this room feeling more energized and more guided on what we can do, and to continue that work and that connection also with Women in Global Health. So first, online, I'm so happy to introduce my friend Anuradha Gupta. You know her now as president of global immunization from Sabin Vaccine Institute, but Anuradha has led such a rich and amazing career that has influenced policies around the world, from when she's been a deputy CEO at Gavi, where all she spoke for and advocated for was vaccine equity, gender, as well as CSO engagement, as well as community-based approaches and vaccine development. She worked at the Indian Admin Service, and there she also, as mission director, really promoted women and children and adolescents and reproductive health. And so her commitment to gender and women is just, phenomenal. You've seen a lot of her policies play out at GFF, some of the child survival work that's been done, and more. I'm also in the room with us, so happy to introduce Dr. Erica Lieberman, who is assistant professor at the University of Rhode Island. She is a fellow nurse practitioner, and researcher. So bringing her clinical, as a clinical provider, her expertise, her research on women and cancer, her passion for women and girls' health that she's had throughout her career, and also leading, oh, great, the Lancet Commission report on women, power, and cancer. So, and then I'm so excited, Tamika Felder, as she walks in the room. Welcome, welcome. No, please. Oh, there's, yeah, 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 we can, yeah, you can also have, yeah, and I can,
I'm totally fine.
okay. So Tamika has been amazing in terms of being the founder and chief visionary officer at Survivor. She's going to share her personal story with us today, her inspiration and leadership that's affected Tamika's and friends, where she influenced and really helped educate not only cancer survivors from cervical cancer, but their friends and families. So I'm really excited that we have these three amazing women. Can we give them a round of applause and welcome? So I'm going to pull up my, I'm using my phone for my notes because we are moving and in our office and we don't have a printer. So I'm not being rude here as I look. So we're going to start with you, Tamika. Yeah, exactly. Well, you want to take a deep breath. Maybe we can get some water for folks. But, you know, you have an incredible personal story. You are a survivor. You're a global cancer advocate. Can you tell us a little bit about your personal journey and some of the challenges of working with the U.S. healthcare system in your journey?
Sure. So for me, it was just a shock. So I had moved to the DC area from South Carolina after college, and I wasn't looking to, oh, if I got a job, what was the insurance benefits package at 25 years old or the early 20s? It just wasn't something that I was into. Now at 48, I want to know what's the package, you know, everything, because now I know better. So for me, I was working in as a broadcast journalist, I had jobs that sometimes didn't offer health benefits. And again, in my 20s, I didn't care. I was like, this job is great. I'm traveling. I'm interviewing, you know, politicos and celebrities and this little Black girl from South Carolina doing what I always dreamed of. So I didn't think about it. And then I got this boil under my arm that had nothing to do with the cancer, but it got me into the emergency room. And we can also have a dialogue about people who have to use emergency rooms versus having a primary care physician, because all of that matters. I don't know if we want to go into that yet, but I just want to put that out there in case we go there later. But for me, without this boil, I probably wouldn't be here with you today. And so I had this boil, had a 5-speed like a good country girl, and on the Beltway in traffic, having a manual car is not the thing. And so it became problematic. And I remember my mom, who was alive at the time, was like, go in, get it checked out. Long story short, during the intake process, they asked, when was your last this? When was your last that? When was your last PAP test? And I thought, I don't know, maybe like 3-4 years ago, something like that. And fast forward, once we got the boil taken care of, the doctor was like, you're a young woman, you need to make sure you stay up on top of your preventive exams. And it's funny because at the time I was like, yeah, give me whatever I need so I can go, right? And I was starting a new job that had health benefits, and he recommended a doctor. And I went to this doctor, and this doctor literally saved my life. She was so thorough. And she had this rule that I had to come back in 2 weeks because she did not have my family history, medical history, all this other stuff. And I was like, I'm starting this new job. I'm working the live show at 6 a.m. I don't have time to come back, right? And she was not having it. She was like, you're coming back, because she literally was checking things from the rooter to the tutor, which, you know, in hindsight, I was thankful for. But at the time, I was like, no. So I go back, and it literally was like an out-of-body experience, like something you would see in a television show or on a movie, because I went in thinking, she's going to tell me to lose weight. which I'm still working on. She's going to tell me to do these things, and then I'm out of there. And she said, you don't have this, you don't have that. But then she touched me by my knee and she said, now let's talk about your pap test. And the bottom fell out. And at 25, I was diagnosed with stage 2A cervical cancer. Technically, that meant it was caught early, but catching it early meant I had to have a radical hysterectomy. That meant that thankfully I didn't lose my life, but I lost my fertility at 25. And I will tell you, it became so devastating to me. And not that I was planning to be a mom anytime soon, but learning that crushed me. It made me think, who would want to marry me? It's so silly now, but these are the thoughts that I had. This was in 2001. By 2003, the first FDA approved HPV tests came on the market. And by 2006, there was a vaccine. So when we talk about winning the war on cancer, for cervical cancer, we can do that because unlike other cancers, and I mean, I've drank the Kool-Aid. Like when they first started talking about this, I was like, what? No. I've lived through my dad going through colon cancer and dying the day before my 17th birthday, many family members. But I know the devastation firsthand about cervical cancer. I started my organization because I survived. We don't hear a lot about cervical, or we didn't in the early 2000s. But now we hear more people talking about it, but it's stigmatized. And so I just want to make sure that one, people are aware of it, they get screened, they get themselves or their children vaccinated, and no one dies from a preventable cancer. And that's what the organization is all about. I created what I wish I had.
Thank you so much.
Thank you.
Yeah, thank you so much for sharing that story. And can you guys hear me? Yeah, thanks for sharing that story. The shock, the reaction that I think a lot of people here can identify with, and where you took that afterwards. And I want to touch a little bit on something you brought up in terms of emergency rooms, the system, and, not only for you, I'm going to open it up to all of our participants about what are some of these things that we see in terms of like implicit bias and prejudice and discrimination within the healthcare system that actually prevents people from seeking care, getting diagnosed, and more. So,
well, I'll share two things. So with the cervical cancer diagnosis itself, I was treated for the most part fairly equally, and I was in good, capable hands. That is with acknowledging that I was treated at Johns Hopkins Hospital, where Henrietta Lacks, who I have to give a moment to give honor to her, because when her cells were taken from her without her knowledge, but also without her, we wouldn't be here today because of all the vaccines, including the HPV vaccine, that her cells have helped to create. So I just want to take a moment to not only acknowledge Henrietta Lacks, but also the Lacks family. But with that being said, when I jump and I talk about the way that I was treated by, and there are wonderful medical providers out there, but all medical providers and medical systems are not the same. So when we talk about implicit bias, buzzwords all around, but these things have been going on for a very long time. They get new names every wave of whatever is going on in generations to come. But I'll give you two examples. One was when I told my clinician that I thought I was depressed. And for me, that was a really big thing, right? But, there is this thing that Black women are strong and all this other stuff. And outward facing, I'm a general happy person. I mean, I even read in my charts how jovial I was. But I think back to that time and I think, how could I not be depressed? I was 25 and I lost my fertility. And I remember my doctor kind of laughing and saying, Ms. Felder, you're not depressed. I know people who are depressed and you're not depressed. And so that was one thing, right? And it could have gone out the other way, right? But I came out of it. I know better. I share the story because I want someone who may not take the information and they do harm to themselves or whatever. I want them to know that I see you, you're not alone. So that's why I share it. That's one example. Another example is when I tried to preserve my fertility, my doctor's fighting for me. And the fertility doctor said, my husband came in his blue collar uniform. And I thought, we wouldn't be at this fertility center if we didn't know how costly it was and all this other stuff. And he said adoption would be the best thing for you. And there's nothing wrong with adoption, but he just assumes we couldn't afford this. And my story has this wonderful ending that I'll share towards the end. But these are just simple things that happened to me that weren't so simple, but there are people who they end up not getting advanced treatment or clinical trials because someone just assumes because they're a person of color, they won't want it.
Exactly. And Anuradha, how about you? Any thoughts on that question about some of the implicit bias, financial burden?
Yeah, so see, I have really seen this play out, as you know, in diverse settings within India, where national statistics can mask a lot of subnational disparities. So sometimes, as Temika said, right, sometimes you see the macro picture, which doesn't actually tell you the whole story about the individual suffering and stigma of certain populations that are living already on the fringes, or where sort of people have very strong prejudices. And we have seen that play out in the attitudes of service providers. So when I was in India, that time, one of the biggest barriers that we diagnosed that was preventing mothers from bringing their children for immunization services was actually unhelpful attitudes of service providers. And there were certain communities and certain households who were not being treated with due respect. And I think that was just a huge deterrent. And when under the National Health Mission, I was standing up this whole workforce of 1 million accredited social health activists who really are our community mobilizers, Lisa, as you know. And they were doing a phenomenal job, but actually I got an evaluation done. And then we found that most of those accredited social health workers actually were from, better off sections of the population. And the most marginalized households were not represented. And as a result, these ASHAs or accredited social health activists actually were not paying visits to the poorest households within the village. And those actually were the households that needed their support most because they actually were suffering from a disproportionately high burden of diseases, morbidity and mortality. So I would also want to share a personal reflection at this point. Last year, my own daughter was diagnosed with breast cancer. And she was at that time only 37 years old with two very young children. And she lives in California, in Los Altos, works for Facebook. And, I saw how privileged she and we were, because, she was under Stanford healthcare, and, she sort of was able to access the best treatment and I kept juxtaposing that experience with the experience that of millions and millions of women, not just within the US. I mean, as Temika just pointed out, there can be sections of population that are discriminated or are unable to access quality health care. But I think in other parts of the world, and cervical cancer is a very big example of that inequity, because we know that, as Temika said, this is one cancer that can be prevented. So when our daughter was battling breast cancer, we knew it could not be prevented, really. But cervical cancer can be prevented. We have the tools, we have the knowledge, we know how to do that. But it is a sad thing that cervical cancer deaths are going up constantly, and 90% of the close to 350,000 deaths that are taking place every year happen in low and middle income countries. And when I was dissecting data, I found that women in Africa actually have 4 times higher incidence of cervical cancer compared to North America, but 8 times higher deaths, compared to North America, which really shows a huge gap in terms of access to the tools and treatments that we have.
Yeah, thank you so much, Honor. I remember that time with your daughter and how she was so lucky that you could provide that support for her also. And so thank you for sharing that. I'm going to shift a little bit since we started talking about low and middle income countries and developing countries, and sort of pose to all the speakers, but I'll start with you, Erica, on what do you think the greatest obstacles are facing women in accessing that cancer screening and care in developing countries?
Can you hear me?
Yes.
Thank you. You know, one of the first things that comes to mind is geography, you know, so we think about rural areas in the US, but in many places in the world, rural means very little or no access to healthcare services at all. And then someone mentioned, I think Rupa was mentioning the competing priorities, especially for women. That's one of the biggest things, right? Responsibilities for childcare, household work outside the house, and the sort of how can women, or how do they choose to, you know, seek care for things like screening, especially asymptomatic screening or early diagnosis for early symptoms. And then other levels that sometimes are culturally bound, but, you know, certainly cross borders about fear, shame, stigma, embarrassment about what can be seen as sort of revealing exams, and discomfort with male providers, or cultural norms around women seeing male providers. And then any of these multi-layered barriers to screening are just compounded if we think then about follow-up for an abnormal screening test. So, you know, women can sometimes come for screening so even in remote areas, maybe there's a health post or a health center in their village. But if they then have an abnormal screening test and need to go for follow-up diagnostic testing, that's most often not in their local area, and it involves travel to a district hospital or beyond, and that might be hours or more. And so, you know, issues around transportation, time, cost, but all of those things these are our most at risk for cancer, are the women with abnormal screening tests. And that's such a barrier, is sort of how do women overcome some of those barriers to get to the diagnostic facility and get as early a diagnosis as possible, and access that care.
No, thank you very much. Anuradha, back to you. What do you think are the greatest obstacles facing women in terms of screening and care in developing nations?
So I want to come back to this issue of compounded vulnerability, Lisa, because I think it's important to recognize that women suffer from one vulnerability, and then, you know, it just gets compounded in a variety of ways. Let me take just one example. For example, like when we were doing this whole data analysis around gender barriers in immunization, what we found was that, you know, there could be, there is an ethnic group living in a remote rural area, and clearly then women or girls in those households have a much higher likelihood of not going to school and not receiving any kind of basic essential services, including, you know, skilled birth attendance, antenatal care, contraception, and things like that. And we know that in a lot of cases, they have to fetch water, they have to do all these household chores, and they don't have access to clean sort of cooking devices, and are often subjected to indoor air pollution. So really all this compounded vulnerability, which makes their predicament extremely unfortunate. You know, for example, we also found that if girls are not in school, right, and they clearly are denied opportunities, right, for growth, they cannot become then doctors. And if they cannot see then male doctors, and in many communities and societies, we see these cultural norms where actually women are prohibited from seeking care from male doctors or male healthcare providers, but then you don't have women doctors, so then it is double whammy. So it is really compounding of vulnerabilities. And now that we at Sabin, we have stood up this global HPV consortium, which is very focused on HPV prevention and cervical cancer elimination. And when we were having this consultation with countries, I was rather struck by one observation that some country representatives made, which was really about this wonderful opportunity that we now have with some of the latest screening methodologies, where women can actually self-screen and self-sample, and a lot of them said that there are cultural norms in their countries which actually discourage women from examining their own bodies, because it is really perceived as something very wrong, morally and ethically. So I just feel that we have to be much more cognizant about the fact that women suffer not just from one vulnerability, but it is a series of vulnerabilities on top of each other, which actually then play out in the very grim disparities that we continue to see.
Thank you, Anuradha. And yes, the HPV consortium network is just amazing how that is taking off and will make a lot of impact, I think, as it unfolds around the world. Erica, I want to go back to you a little bit about the scale of cancer and globally and that challenge, especially in developing countries. And what do the cancer rates look like now and in the recent years?
Yeah, so in 2023, there were over 9 million women were diagnosed with cancer, and 4.4 million women died. And those rates are predicted to rise by about 44% and 60% respectively by 2040, which means we're more like 13 million women a year diagnosed and 7 million dying. And that proportionately, that rise is expected to be steeper in low income settings compared to high income settings. So overall risk of being diagnosed with cancer in your lifetime is higher for women in high income countries, but your risk of dying is about the same regardless of where you live, which is sort of out of proportion with the cases. Optimistically, of the 2.3 million premature deaths, so women diagnosed prematurely before age 70 yearly, we estimated on our Lancet report that 1.5 million of those deaths could be averted through effective primary prevention and early detection and screening strategies. So there's the work that we're all talking about here is really essential in terms of having an impact on that trajectory globally.
And you've spearheaded the Lancet Commission on women, power, and cancer. And I think that's really brought a lot of global attention to the issue. Can you maybe share some of the top recommendations that are from that? And the link to that report is, I believe, in the invitation. So you can all make sure that you access it later and read it, besides the quick recommendations that we're going to get
Snippet,
right now.
So thank you for that and for the invitation to be here. I was one of the commissioners among over 20 commissioners led by Ophir Ginsburg, Verna van der Prie, and Isabel Sotomayor at IARC. And it was a tremendous effort and labor of love over 3 years really multidisciplinary effort with brilliant folks. So I was honored to be part of that. And we really took an intersectional feminist approach to looking at women and cancer, and women and power and cancer, and that nexus, and looking at sort of asymmetries of power and what women face in terms of access, some of the things we're talking about, right? Access to information and knowledge, access to economic resources, access to, or decision-making power, right? And the ways that sort of impacts the layered vulnerabilities that Anuradha was talking about. We have about 10 key recommendations that are in the process now. This next phase will be sort of developing metrics for monitoring and evaluating progress on that. And really that's a part of the it's designed to be sort of a call to action, but I'll highlight a few that I think are most relevant to this discussion. We talk about the need to design gender transformative, and thank you to Women in Global Health for sort of advancing this language about the gender transformative, intersectionally transformative health systems, and especially in terms of promoting equitable access to early detection and early diagnosis of cancer. So that means all the things we're talking about in terms of understanding the individual, interpersonal, health system, sociocultural landscape and layered barriers that women face. And then also making sure that the health systems are responsive to the needs of women, gender responsive, accessible, and provided with respectful, high quality care for girls and women. And the idea of like sort of co-creating what that looks like, what that means. And that means enlisting the help of a whole movement, right? And community partners in civil society, in international organizations, in governments, et cetera. And then a few points on the sort of health workforce, and knowledge generation end of things. There's a need to promote increased women's representation in research, in access to leadership opportunities, and to Rupa's point about sort of, we know that the more is women led, the more is going to be ultimately more gender transformative, gender responsive. And so those are very clear metrics, right? By X year, what percent of oncology journals editorial board should have equal representation of women. So those are some where they're very concrete metrics we can watch. And then also, my colleague Nazak Hamad in Canada and Sudan really worked hard. I worked closely with her on proposing a gender competency framework for education and training of health professionals. So some of what we're talking about in terms of implicit bias, racism, homophobia, sexism, all the things that people face all over the world. Not just understanding. So as people are in their training across disciplines in nursing, medicine, allied health professionals, really at that training level, not just understanding health disparities, health policy, health systems, but if promoting effective provider-patient communication, addressing some of the barriers that arise when there's provider-patient discordance along lines of race, gender, both, and what that impact is for patients. So that will be in continued development in terms of advocating there. And then a piece that our sort of economics experts looked at was really trying to value and develop pay standards for cancer caregivers, right? So outside of the formal workforce, but valuing and investing in what we know is a huge economic burden and important role. Those community-based health workers, but even family members providing care, and how do we really account for that? So those are some of the highlights, but yes, I welcome. And the link is there. It's open access completely till next week, but then after that, just by registering with the land behind it, so easily accessible. And we invite input and collaboration.
Absolutely. I'm sure everyone in this room is sort of writing down the next steps so that they can participate. I think some of these hit home for me, working in Sri Lanka, where they would have the mobile cervical cancer screening, and going on monitoring visits and seeing leading the women into the schools, and they had put a sheet on the teacher's desk for them to lay on, and saying, well, you have this incredible, $100,000 mobile unit. Why are we laying women? How is that respectful on a teacher's desk with a screen? And sometimes if we're not thinking about these issues from a systems point of view, from a provider point of view, from the communication point of view, and then something you brought up earlier in terms of just notification of the screening and how they get results, and that compassion and that care. So I'm very excited. I know Nicole is smiling down on us. That bring it to a topic that some of you might be thinking of. I am, and that is aging. We noticed that there's been a lot more funding for aging in terms of menopause by as soon as certain donors reach a certain age. It's very interesting, isn't it? You know, once they're in their late 40s or 50s, suddenly there's menopause funding, you know. I don't know. It's what is that? I don't know. But in the Lancet report, you know, there were approximately 411 million women that are age 65 or older in the world, which means that almost half of the cancer cases among the women occur in just under 12% of the entire world female population. So when we're thinking and so showing that cancer is strongly associated with aging, and we know that there's a lot of discrimination around aging, it's usually not funded. There's a lot of discrimination, sexism, patriarchal, especially in low resource settings. And Tamika, I'm wondering, in all of your work and all the people that you've been assisting through the Friends and through Survivor, have you seen some of these issues with aging, and
Absolutely.
you know, how do you think we can get around it? What do we need to do?
You know, people are living longer. People are, you know, I spoke to a group in Alabama not too long ago. First it was the physicians, then it was the doctors. And one of the things that was striking to me is that they were like, we want you to talk about sexuality and intimacy with this group of cancer patients who were mostly, I would say, 56 and up, a good percentage of them being in their late 60s, early 70s. And they all wanted to talk about it. And then when I got with the physicians and I said, well, why aren't you talking about it? They were like, well, we just assumed that they weren't being sexually active. And I was like, well, why? Do you not want to be sexually active when you're in, you know, later in life? And, you know, and yes, maybe I'm from South Carolina, so we shouldn't be talking about these things. But the reality is we want to look at the whole life of someone. So when I think about survivorship, right, what is the quality of life? Not just surviving, but what is the life like beyond that cancer diagnosis? That includes sex, that includes intimacy, that includes menopause and the side effects that are very real, the brain dysfunction, all of these things beyond the hot flashes. And so, yes, we also see that when it comes to treatment options, that, you know, some people, some clinicians just say, well, they had a good life and, you know, if they had this, maybe it'll kill them instantly. And we see patients saying, I'm not done yet.
Yeah.
I'm willing to try because I'm not done yet.
Yeah. So going back to listening to the patient and really
Absolutely.
advocating for them.
Absolutely.
Yeah.
And patients are advocating more and more for themselves now. You know, we're in this age of social media and all this other stuff where it's like, you know, we're in this together. This is how you fight for yourself. And if you can't do it, here's how you arm yourself or bring in an ally to advocate on your behalf.
Yeah. No, that's really great. And I'm glad that you can share that from the perspective of the survivors also. Anuradha, what do you think in terms of aging and how we can better address some of these intersecting challenges in terms of cancer and women?
Yeah, so I think we sort of need to segment, right, the populations, and because the way we approach care, you know, would undergo a lot of change based on, you know, what age group are we really talking about or looking after. Because I think based on what Erica was saying, I think there is also this mounting concern about young women dying prematurely of cancers. And really the social, economic, and emotional costs of those premature deaths are very high. And for example, if you look at cervical cancer, then you see cervical cancer incidence rising among younger women. And there you must have read in the news very recently a very young Miss Uruguay, you know, dying at the age of 25 of cervical cancer. So I think there is younger women are facing today a very different kind of challenge in terms of what seems like an epidemic of cancers. And as I said, a lot of this is disproportionately concentrated in low and middle income countries, because that's where access to the timely care or treatment is also quite deficient. But no matter, regardless of what country you are looking at, we do see a lot of disparities, which are geographical disparities, which can actually be ethnic disparities, which can also be certain comorbidities, right? For example, HIV. Women living with HIV actually have 6 times higher risk of developing cancer and really dying of cervical cancer, in a much higher proportion. But also we found that cervical cancer among women living with HIV actually progresses much more rapidly, between 5 to 10 years compared to 15 to 20 years in standard population. And then, of course, there is a nexus between poverty and cancer incidence. And we don't have very nuanced data, but we do have directional data to show that there is a link between poverty and for example, cervical cancer and cancer incidence. And that then in turn is really linked to this whole question of, for example, how do you reach out of school girls, with HPV vaccination or screening provision, right? Because if our vaccination strategy is really contingent on school-based campaign, but in a lot of countries, you have 50 to 70% girls dropping out of school, at the primary stage, then, are we really thinking adequately about those girls, and how do we take care of them? And then, of course, there are non-binary groups, Liza, right? And I have started, for example, transgender individuals who actually are not even a part of the SAGE guidance. If you look at this whole HPV vaccination strategy, it talks about boys and girls and gender-neutral vaccination, but it doesn't recognize non-binary identities and transgenders who actually are at much higher risk. So what I'm saying essentially is that we have to really dissect and unpack this whole thing, so that we can see what kind of age groups are we looking at, and where is it that the costs are the highest. And then, of course, when you have cancers developing among more elderly women, then the kind of access or the kind of care that they need is going to be very different, including palliative care, because in many cases, palliative care will also become very important. And unfortunately, in resource-constrained settings, palliative care is nearly sort of absent.
Thank you, Anuradha, and for bringing up not just the ageism side of things, but the hot topics with girls, and then a lot of the discussions and heated discussions, I should say, about the language and recommendations for SAGE in terms of non-binary and transgender people. Erica, over to you. What do you think are some of these better things that we can do to better address ageism in that intersection for cancer?
I mean, one of the things that strikes me as Anuradha is talking about, kind of the need for tailored health messaging, right? So some of where women get missed in terms of screening, particularly, is it not resonating, right? So the lesbian woman who none of the health messaging is directed towards her, so she doesn't think she needs to be screened, or and so it's a little bit tricky in terms of age, because in many settings, women who are 65 and older may not be part of the target population for breast and cervical cancer screening, right? Just based on sort of priority target population. But so certainly any of the efforts in primary and secondary prevention that we're making will impact future generations of older women, right? If we do that well. But but there is a gap even before people are outside of sort of the target screening range. This idea that a lot of screening is tied to is delivered in family planning settings, reproductive health settings. So as women age out of that sort of childbearing years, feel like it doesn't apply, or they're just not going anymore, whether it's in the US or other countries that So I think there's a window. It's not a good experience. Who wants to do it? Right, exactly, right. Yes, exactly. But so, you know, catching that sort of window. And I know in the US also, some of it is confusion around guidelines with providers not knowing that, you know, who's at most risk. So we're seeing in the US certainly an increase in cervical cancer in women in their 60s and 70s because they've been under-screened, right? So yes, we can stop screening at a certain age if people are up to date on screening. But so I think it's a combination of messaging that's appropriate, that's culturally tailored, that's context specific, that's age specific. I think there's lots of material there to, as Arundhati is talking about, just sort of who do we need to speak to, right, in terms of our messaging and programming, and how do we bolster sort of our general primary care systems that are not so sort of program or specialty specific, where a lot of women's screening happens.
Yeah. Thank you. And that integration, it's just not screening as in a bucket over here, but it's tied to more primary health care on a regular basis. I want to make sure we get to questions too. So I'm going to turn it over to the audience. We're going to get their questions. Then we'll go back to some questions. I know, Anurada, you have to leave about 6:20-ish.
Yeah,
Ish, yeah, 6:30. So questions from this amazing group of experts and leaders in global health. I don't know if we passed the. And introduce yourself too, please.
I think what you were saying about the guidelines is very important. You know, I was just browsing social media one day and it was like on I can't remember what page, but it was a big platform and they were saying like, oh, my doctor said I only need to be have a pap smear every 3 years. And I find like I'm hearing a lot of that a lot more. Whereas like, you know, personally, my provider she's every year, like she will not refill your birth control or anything if you don't come in within the year for your pap test. So I think that there like, I mean, and I'm sure it's all over, but I think that there needs to be some more structured guidelines on like how often you should be screened and what age, and like really push that messaging out to people. Cause I do think that there is starting to be a lot more confusion around that.
Thanks, Tamisha. Any comments?
Yeah, so if I could just make a reflection here, Liza, and that is that I think we are not moving fast enough in terms of our policy and programmatic response, right, to some of the developments that we are seeing, frankly, right? The disease is evolving, you know, its profile is changing, but I don't think the policy regime is actually keeping pace. For example, pap smear, now we have much better and more sensitive tests, you know, HPV DNA testing, right? And even in low and middle income countries, this whole PCR testing capabilities that got built during the pandemic can be so easily and smartly leveraged. And yet, you know, pap smear is the default response, which is so much more expensive and, you know, is more complicated. But and what I really found very intriguing was the fact that insurance companies in most countries have not started to reimburse some of these newer and simpler screening technologies. And somebody actually in Malaysia raised this issue, saying that they are increasingly encouraging these newer ways of screening HPV, cervical cancer screening, but insurance companies are not recognizing. So clearly then healthcare providers would fall back on more expensive tests, pap smear, and then you do that not every year, but once in 3 years. And similarly, when we are talking about screening, so in a lot of countries, you know, for example, mammography gets done the first mammography is recommended at the age of 50, but actually now you see much younger women, right, developing breast cancer, and of course those who have a genetic predisposition. And I don't think we have tailored strategies to really prioritize some of these groups and actually change guidelines at the pace at which it is needed.
Thank you. Did you?
Yeah, I was just going to say spot on. You know, that's why they have shared decision making. But then what is shared decision making, right, between you and your provider? But you know, it's great that we have these guidelines, but it's not a catch-all, like go when you're 40 to get a mammogram. And, you know, as you just said, like that's even changing because especially if we look at triple negative breast cancer and all this other stuff. But yeah, there is information and a marketing problem surrounding HPV and cervical cancer.
Absolutely. And I'd say there have been evolving guidelines based on good science, but the implementation of them has been very uneven and confusing. And providers will say, I don't want to do HPV testing because then I have to explain this whole thing to my patient. You know, it takes too long, right? Right. But so there's a lot of confusion, and we see that even that we need better the patient level understanding and community understanding of what the recommendations are, better communication between providers, and then providers need to understand the guidelines better. So it's we're caught a little bit in what's happening of we have historically been doing more testing than we needed, but now there is sort of I also think we have to trust women to not have this obligatory, like you have to get in order to get your birth control, you have to get your pap smear. So that's not the right strategy, but that we come from that reality to then we're saying we can extend screening, but it's like we don't trust women to digest the information and be proactive in terms of their own health. So it's a very sort of paternalistic system still. And then layer on that, at least I'm talking about US context right now, there's payment that's linked to an annual exam. And so that's a policy issue that we need to advocate for, to sort of parse that out, that you could get your screening. Maybe some people do need to get their screening in the emergency room because that's where they go, or that, if that's the only place they're going to access screening, or at least not have to have it be that they come for their annual exam. So there are a lot of layers to that, but I do think that more widespread education on HPV and cervical cancer and what the screening guidelines are and why, and that it's not.
Thank you. Yep.
Exactly.
Thank you so much, Erica. We're going to go to a question online right now. Liz, do you want to go ahead and? Okay, Alexis, do you want to come off mute and
Yes,
share your question?
I'm going to turn on my video really quickly. I look crazy, but I don't want you to talk to the void. Hi. So
Hi.
Alexis Barnes. I work with a public affairs agency. Can you hear me?
We can go.
With biopharmaceutical companies and their social impact arm. We're trying to increase innovative treatments to lower and middle income countries. And so my background's in public and global health, but I'm really grappling now, this is from a global context, on the barriers in terms of supply chain and the capacity on the ground to store and house the therapeutics, et cetera. And I'm really struggling with how it seems really insurmountable. My background is also in improving cancer screening and community outreach in that way. And so it's the first time that I have to think about, I know the conversations on UHC, and we do have a couple of MOUs, for example, in Cote d'Ivoire, where now screenings are free. I saw somebody in the chat mention Nigeria, which is awesome. But from here to there, that road seems so far, and it's a bit discouraging sometimes. So I don't actually have a question. I just wanted to bring that to the table.
Yeah, thank you. I don't know if you have comments on that. You've been so much in the diagnostic and vaccine delivery.
Yeah, so I think this is absolutely the right issue to raise, and everybody's concerned about this. But I'll tell you what I think are the two key culprits here. One is that historically, the funding, like Lisa was talking about, the funding or incentives or perverse incentives. I call them perverse incentives. So I think the way the funding, external funding is structured, that actually injects a lot of perverse incentives to continue to do things in a very vertical manner and highly siloed, highly fragmented. So because there isn't a unified approach, therefore you are not making your investment smartly. So these countries therefore are unable to actually conceptualize integrated supply chains or bring a systems approach to some of their public health challenges. So to me, that's just one issue that needs to be tackled. And from the global HPV consortium standpoint, I am just saying we need to integrate, because finally it is cervical cancer that we need to control and eliminate. And for that, vaccination is important, being primary prevention, but there is also secondary prevention, which is screening and treatment of precancerous lesions. And let's try and support countries to bring it all together. But there is an argument to actually support countries in doing comprehensive cancer control strategies, frankly, of its cervical cancer. So I think, this whole idea of integration, because if we are able to encourage countries and support countries, then it can be so much more cost efficient and also effective. So at the second really issue that comes, and I feel that's also a culprit, is sustainability of financing. Right. So the point is today, so some find there is no funding stream at this point at the global level, which is providing countries funding for all this screening and treatment and integrated strategies in a holistic manner. It is very patchy. It is very uneven. In some countries, it is restricted to patients living with HIV or things like that. And the duration or the life of that external funding is absolutely not predictable or certain. So with the result that if there is no domestic financing or there is no plan to mobilize political will and domestic financing, you would see these interventions dissipating sooner rather than later, and that would be a huge tragedy.
Thank you so much. And thanks, Alexis, for your comment. Ruben, do you have a comment, question?
I had two questions, and what a great I think one is related to looking at the broader drivers of what's causing it. I know we don't have all the answers, and as one of the themes that came up in today's talk was that we're seeing women at earlier age have cancers, and just more widely, we know there's many factors to that. I wanted to inquire a bit, what are you seeing from the commission findings and Anuradha as a global leader on addressing the commercial determinants of health and the environmental determinants of health? And as a physician, I could say that, I also am witnessing, but I know there's some minimal studies that have come up in countries showing that the prevalence is increasing at younger ages, but we don't have a full system. How can we also look at those commercial determinants, those environmental determinants, and I think particularly with the commercial determinants, use them even as a mechanism to increase industry that is promoting alcohol, industry that is promoting tobacco, women consuming those goods at higher rates than traditionally done, also impacts why they're having these cancers. I'm curious about that. And I think the second question is related to being patient-centered. And I would say not just patient-centered, but female-centered and women-centered, because there are unique needs that women have. And how can we make sure that in global health cancer equity, we're really bringing that aspect forward? Recommendation.
Anuradha, since you have to go, I'm going to ask you to go first, and then we'll go to Sean.
So my apologies, I couldn't get to the first question in total, but let me I think I did hear her mention environmental and commercial determinants of some, if I understood her correctly. So I think the Lancet Commission that Erica was a part of actually highlights that very beautifully, where they are talking about commercial determinants and saying how there are certain beauty products, for example, that are suspected to be increasing the incidence of certain cancers. Also, the kind of body image that is being promoted. So if women are, if you really want those zero size figures, and you are actually encouraging women to not eat or properly or have a more balanced nutrition, what kind of impact it has on women. So really commercial determinants. So I think commercial determinants are important. I think also this body image issues and self-image, and that then verges on this whole debate on sexism. Who do we think is a beautiful woman, right? So and what is the role that women themselves can play in perpetuating a definition of beauty which is really about a healthy woman more than anything else. So I think that's and then of course environmental factors. So we said that's also, I think the report, if I remember it correctly, the report also talks about environmental factors. The kind of the rampant use of pesticides, also the cleansing agents that women are using. But as I said, in poorer and resource constrained settings, the cooking devices, and the smoke that women have to inhale is also a very big challenging factor. And the third thing that I think, Rupa, I would want to highlight before I leave is really seriously thinking about how much of pressure today's norms are actually putting on women. For example, we want women to be achievers, right? And to have their careers, but we've also seen that where women are sort of career oriented and very successful, their biological clocks and their career clocks are actually clashing. And and in fact, my own daughter, who had the meteoric rise at Meta, actually wrote about that when she fell a victim to breast cancer, to say, when her career was really soaring, that is the time when she was also giving birth to 2 children, right? So and so she was a mother of 2 young kids. It was very hard on her, and then then having to deal with the soul disease. So I think there are many things that we have to absolutely think about and say, how do we take a lot of self-generated pressure off women and be more realistic about their what they actually want to achieve in life and what they can do in life, rather than artificially getting them under undue pressure.
Thank you, Anuradha. Such wise advice. And thank you so much for joining us. I know you have to go. Zoom will stay open. Can we have a round of applause for Anuradha, please?
Thank you so much. It was such a pleasure joining this.
And thanks so much for all the work you do for women around the world. You've done this your whole career, and we look forward to hearing more about you and also Sabin and how they're going to address this issue.
Okay,
Thank
bye-bye.
you, Anuradha. Turning it over to our colleagues in the room. Would you
Yeah,
like to tackle those
I can
questions?
certainly make a couple comments about, so interestingly, Anuradha ended on a note that where we, about the sort of gendered experience, but we can talk about protective factors where policy can impact things like breastfeeding. We know can reduce the breast cancer risk, but there's a need for supportive policies in workplace environments to support breastfeeding, right? That's an example. And then, yes, we did start to get it in the commission report at kind of emerging risk factors, and a push for more research on to define those, right? And to really look at those correlations in terms of the whole cosmetic industry, and in thinking about Black women specifically, and hair straightening products and skin bleaching products and things like that are used in various places. Again, we can dissect those sort of what are the beauty norms and standards and racism and sexism embedded in all of that. And then other sort of aspects. So there's not clear evidence yet. We couldn't present anything. There's certainly suggestive drivers of sort of beyond just demographics, but in suggesting that is part, at least in breast cancer, part of the increase among young women and women in general. And so a definite need for push towards more research on environmental and product and commercial determinants of cancer. And also then the cook stove and, all that sort of indirect and increased awareness about women's risk for lung cancer. So I'll leave it at that.
Yeah,
yes,
thank you.
yes,
We could go on for a couple more hours, right?
Definitely a need for research agenda. Yeah.
Tamika?
Well, first I want to say I'm okay looking like this and like this.
Beautiful.
I just think, we have to keep going. That means patient voices. That means you all, everything that you're doing, because we have to strive for people, not just in the US, but around the world, to get better, be healthy, and really everyone have equal access. one of the things that's the hardest for me is when I think about my own cancer struggles, especially as a Black woman, and overall having a good experience, but then I talk to someone who is in rural Georgia and they say, oh, my doctor just gave up on me, and they send me a message and it's just heartbreaking. Or the person that, their job doesn't understand that the gynecologic oncologist is 3 hours away, but what are they going to do for childcare? Or when I talk to people who don't understand that there are food deserts. So I think my goal is just keeping patients forward, making sure that we change laws to ensure that there's funding, political will, all those other things, but also just not stopping, because sometimes doing this work, it seems like, are we moving the needle? Are we getting anywhere? And I want to say, yes, you are. It's slow sometimes, but we may not see the benefits of it, but future generations will.
Thank you. Oh, man. I'm going to stand up for the next one. Yeah, I mean, that is. So one of the reasons we're here is for our dear friend, Nicole Schiegg, and she was a tireless advocate for women's health, and especially the prevention, the care, the treatment of women and cancer. And so you have a room full of advocates and women interested in women's health and cancer care. How can they do better and take all of this forward? How can we keep that incredible legacy of Nicole alive in this room and in all of our actions?
My friend April Capel is a metastatic breast cancer survivor. And one of the things she always says to me and people in general is, this big world is made up of all of us. What will you do? And the world has all these cracks, right? We can't take on all the cracks, but what will be the one crack in the foundation that you focus on? And I would say, how are you going to leave a lasting legacy, a little piece of you behind? And clearly, Nicole left a lasting legacy. So I would challenge each of you to think about, what would your legacy be? And what will you do to create good in the world and make a difference?
Thank you.
Yeah, and I'm sorry to not have met Nicole. She sounds like quite a beautiful, bold person and really did important work. And on a very fundamental level, I think we all need to continue to center and uplift women's voices, women's stories. Be kind of unapologetic and not afraid to stumble. I mean, you just mentioned, how do I look in this picture versus this? Like, just supporting women, right? Just come as you are, show up as yourself, speak your truth. Another sort of feminist principle that feels like, the personal is political, like talk to your sisters and your mother and your aunties and your, right? Like, let's talk about this. Let's destigmatize, but sort of spread the word, advocate for yourself, bring, and push for more accountability in terms of, I am a healthcare provider, right? And I value most my relationships with my patients, but I need my patients to tell me when I've stumbled, and I, hope that I can venture to be brave enough to apologize and move on and repair, right? So some of it is very close interpersonal, and some of it is just doing the work. But the little bit I read about Nicole also made me think that we've got to laugh, we've got to be joyful, right? The way forward is hard, but it's also, we've got to have some fun. We've got to support each other. And I think those are really important principles of feminist leadership that I think Women in Global Health is really living and breathing and advocating for. And that's what's going to move us forward, right? Let's just do this our way, right?
Thank you so much. And let's have a huge round of applause for Erica and Tamika. So thankful to Lanice, who chairs and leads the DC chapter, and of course, the amazing Dr. Rupa Dutt, who started this movement. I'll turn it over to Lanice for some closing remarks and instructions, but my pleasure to be with you and so lovely to meet all of you. I hope we stay in touch. Thank you.
Hi, everyone. Thank you so much for joining us in person, and for those on Zoom, thank you so much. I know Nicole's mom, oh, sorry, let me scoot over. I know Nicole's mom, Esther, is online. So hi, Esther. We're so happy that you were able to join us. And I know you are extremely proud of this event, but we know that Nicole is not physically here, but here with us in spirit. And we know if she was here physically, she would be proud, but we know right now she's smiling down on us. This is, as you know, we're navigating a new normal with COVID still lingering, but this will be one of many of future events to come for our chapter. We plan to do something each year to honor Nicole's life and legacy and her contributions, not only to global health, but advancing equity, particularly for women. Especially, we knew from the time of her diagnosis in 2020, she was very passionate about ensuring that all women, regardless of their race, class, gender, and ethnicity, had equitable access to cancer care, screening, but as well as prevention. So thank you again to our partners, the UN Foundation, for granting us the space, as well as to Global Health Council and CD Roundtable. We look forward to seeing you at a future event. If you have any questions, you want to talk about getting involved with the DC chapter, you can speak to me, Liz, Elizabeth, Kamisha, and there's a couple other executive committee members that will be joining us. And you can also email us at WGH-DC@womeningh.org. For those that are here, we'll have a networking reception. And again, thank you to everyone for joining us.